So, good evening, ma'am. So, I'm presenting
Yes.
the history of a patient, 50-year-old male, Mr. XYZ, who hails from Kolar, who works as a school teacher by occupation, who was examined on 18th of August 2020. The informant was his wife, and the informant history is reliable. The patient came with chief complaints of sudden weakness of the right upper limb and lower limb since 3 days, and he noticed inability to speak since 3 days.
Yes, ma'am.
Coming to the history of presenting illness, he was a left-handed gentleman. He was apparently normal and in his usual state of health. He was able to perform his routine daily activities until 3 days back, when patient was all right at 1 p.m. when he went to sleep, and when he woke up at 4 p.m., he had a fall when he tried to get up from the bed. Following the fall, after about 10 to 15 minutes, patient noticed weakness in the right upper limb and lower limb in such a manner that the patient was unable to hold objects like glass of water in his hand. However, was able to move his arms. He was able to raise his arms. However, was unable to grip objects with his right upper limb. He also noticed the weakness in the right lower limb, such that he was unable to walk and required the support of his wife to walk. He also found difficulty in gripping his slippers and walking. 30
Yes,
minutes
ma'am.
later, patient noticed that he was unable to speak. However, according to his wife, he was able to understand and obey commands, and was also able to identify objects. But on attempting to speak, he was not able to speak. Because of the background history of diabetes, the capillary plasma glucose was checked, and it was reported by the wife to be 89 mg per deciliter. At or before the onset of symptoms, the patient and the informant denied any history of headache, nausea, vomiting, or any aura preceding the event. There was no history of fever, night sweats, or weight loss. There was no history of any head or spine trauma. There are no history of any involuntary movements, uploading of eyes, urinary incontinence, or any loss of consciousness. There was no history of palpitations, breathlessness, or loss of consciousness. There is no history of any surgical or dental procedures performed in the past. Following this, the patient was taken to the emergency room and was brought to the hospital in an ambulance. In the ambulance, after admitting to the emergency room, the patient noticed that the weakness had progressed in such a manner in the upper limb such that he was completely unable to move his entire right upper limb. However, the lower limb weakness remained the same. However, he complained of a feeling of heaviness in his right lower limb, and he required support to walk. And as reported by the patient and his wife, the patient had no history of any loss of sensation, such that according to the patient, he was able to appreciate the clothes he was wearing or denied any burning sensation in the limbs. He also denies any history of involuntary movements, bowel or bladder incontinence. There is no history of persistent vomiting, giddiness, tremors, or headache following the weakness. There is no history of blurring of vision, double vision, deviation of angle of the mouth, drooling of saliva, difficulty chewing food. This was at the level
Yes.
of history, ma'am.
Okay. We will analyze symptoms one by one.
Yes, ma'am. Should I finish
Mm,
the significant past history because he has.
Okay. Okay, ma'am.
Yes. Past history, he's a known diabetic since 10 years, has been on regular medications, which was metformin 500 mg twice a day since 10 years, and he's on regular periodic follow-ups and has been told his sugars were under control. He's also a known hypertensive on tab amlodipine 5 mg once a day, and he's compliant with his medication. There is no history of any rheumatic heart disease, ischemic heart disease, tuberculosis, asthma, reactive airway disease, or seizure disorder. There's no history of previous admissions to the hospital or prior surgeries.
Okay, ma'am.
Family history, he lives with his wife, who's a primary caretaker. He has two sons, both of whom live separately. There's no family history of stroke or migraine or any cardiovascular events in the family. The patient consumes a mixed diet, which consists of both vegetarian and non-vegetarian diet. He was able to perform his activities of daily living until the onset of the weakness, and currently is requiring support for his daily activities. Sleep, according to the patient, is undisturbed with no bowel or bladder incontinence. He is also a reformed smoker with history of consumption of 2 packs of cigarettes per day for 15 years, stopped since 3 years. He denies any history of any ethanol consumption or any high-risk behavior.
Want to summarize, ma'am?
Yes, ma'am, I'll summarize.
Or we, yes. Or we can go through. You have made the details, no?
Yes, ma'am.
So you only will discuss. Okay, you said that he went to sleep in the daytime,
Yes,
and he woke up and he had a fall, no?
Yes, ma'am.
So what do you want to think about that fall, ma'am? Was the fall responsible for anything? Because there was a gap according to you.
Yes, ma'am.
Following the fall, when you noticed the disability, no?
Yes, ma'am.
So he fell down from sleep. Did he have any preceding symptom before he fell down? He slipped and fell, or he had a seizure or loss of consciousness or giddiness, anything?
He denies any history of any loss of consciousness, giddiness, or prior to the fall, ma'am. When he tried to get up from the bed, he said he had a fall.
So what are the points you will tell when somebody says the fall could have produced the neurology, or neurology could have made him fall? Both are possible.
Yes,
no.
ma'am.
So when you want to know a fall as a significant fall, what all questions you'll ask me?
One is loss of consciousness.
Yes.
Involuntary movements.
Yes.
Any giddiness.
Yes. So you have got 2 types of faults. One injuries. One is the dynamic injury and another is the static injury. No. So from a fall, whether the patient acquired any dynamic insult or static insult. You know, static insult or penetrating injuries. You can hit your head, have an extradural or parenchymal bleed. So that symptoms will be loss of consciousness, convulsions, and vomiting, and going into unconsciousness and not getting up. So they are penetrating injuries, and there will be evidence for local injury, and the site of hit will be identifiable. Whereas dynamic injury, he got up from the bed. This dynamism can be applicable because he was in the static position and he fell down. So dynamic injuries produce some small things, and the complications can be later. So whether he had vomiting, whether he had any bleeding from the nose, bleeding from the ears, any arteria, rhinorrhea, and as he said, transient loss of consciousness. Unlike penetrating injuries, based on the type of injury it has caused, patient will have sequelae immediately. Whereas dynamic injuries, he can have later. Immediately he may lose consciousness, but he can dissect his carotids, or he can get a whiplash that can produce quadriplegia. No? So all these things are whether he had, so none of these symptoms like vomiting, rhinorrhea, arteria, nothing was there. So he is unable to tell us. So the injury does not seem to be really significant. Injuries can produce focal neurological deficit also. Trauma can produce a shearing stress on the intima, and they can dissect their arteries. So dissection, traumatic dissection. So as per the history, nothing is appearing relevant. So the trauma was probably not the culprit. It could be that the trauma is the fall is the effect rather than the cause. So it is likely. We don't know. We are not drawing any conclusion because we have thought about so many symptoms. They are not available to us. So we'll presume that probably trauma is not the cause. Probably it is the effect. He might have lost some balance and he would have fallen and unable to tell us. And immediately you told that sometime later he noticed that he is not able to use his right hand.
Yes, ma'am.
So when patients come to us, they come with a group of functional disabilities, no? Yes, like what you're unable to hold a cup. That's what you told.
Yes,
and these functional disabilities, first what we do is we just listen to the functional disabilities, try to analyze. So what are all the functions they are lost in this patient or altered in this patient. And then after that analysis, the next question will be, does this functional disability has an anatomical correlate? Sometimes anatomical correlate may not be there. Then we will think of non-neurological conditions, no? Or non-territorial conditions, infiltrating lesions, cross-territorial infarction. So whether this functional disability has got an anatomical correlate or does not have an anatomical correlate. That is the second thing we will want to infer. Then the third thing, if the anatomical correlate is there, the symptoms available so far, does it point to a pathology? Non-pathology, less common pathology. Then next, is it having an acute onset and regressing, acute onset and progressing, subacute progressing, relapsing, remitting, steadily progressing. So this much information from the history will make us sit somewhere on the diagnosis. So these are the things. So in that way, we will try to find out. You told that he's a left-handed person, no?
Yes, ma'am.
Little less common in the society. Majority of the people are right-handed. A small proportion is left-handed. So how did you decide he is left-handed? What are all the methods we use to know the handedness? Then we will analyze the relevance of handedness, and then we will go. That's the first symptom. You are written left-handed person, no?
Yes.
How did you decide his handedness?
One, which was the dominant hand he uses for his routine activities, ma'am.
Yes.
Other way of testing is that would be an examination wherein a sudden object, untrained activity if given, which is the dominant side of the body he is using. Like if we ask him to walk, which is the first limb he tries, or while throwing a ball, which is the first hand he uses to catch or grab the object, that would be the way we think of handedness, ma'am.
So one thing, as you said, patient himself says, I am a left-handed person. So it's a subjective information about his handedness. Was he shifted? That usually we ask when they are right-handed, where they shifted from the left-handedness to right-handed. But doesn't happen with a person who claims to be left-handed. Then what you small things, it's very, very important because it is important in language, localization, epilepsy, surgery, no?
Yes, ma'am.
So it is preoperative tumors, no? You want to know how much is the prognostication when the tumor is removed, is the patient going to lose his language? So all those things are important. So handedness is important. So one thing we will tell, handedness goes with eyedness. That's the simplest thing. You have this illuminoscope, no? When we are in the surgical wards, we use one illuminoscope to know transillumination of cystic and solid lesions.
Yes,
you know that, no? You roll up the X-ray tube and X-ray film and use it. Yes. So you tell the person to focus on a light with a rolled up X-ray tube. And your handedness goes with eyedness. Normal people who are right-handed or right-eyed, left-eared and left-footed. The majority, 91% is right-handed. They are right-eyed. Left-eared, left-eared. Dominant leg is left. Dominant ear is left. The land phones are designed for the left ear only. And in traditional families, people stand in the door when marriages happen. You put your right foot first because your left foot will come. Because the dominant foot is left. So easiest to check is the eyedness. So you can tell the person to focus on some light. So one thing to know handedness is eyedness. Second, we tell cling like this. The dominant thumb will be down. Just a cling without thinking. Both hands like this. The dominant thumb goes down. That is another objective thing. Then there is something called, which you told only, but it is under a proper name, Edinburgh's Handedness Inventory. It is called Edinburgh's Handedness Inventory. There are two inventories. One is for bedside, another is for research purpose. For bedside, you have got 10 points. You told some of the activities that we do, no? Yes. Out of the 10 points, if 8 activities are done with one hand, that is a dominant hand. And there is a 21-point Edinburgh's inventory that is used for research purpose. For routine purpose, you use a 10-point Edinburgh's handedness inventory. So those are 3 simple methods we can use. Then you can use the EEG. EEG is available everywhere. You see, we think that the non-dominant hemisphere is relaxing. When we are talking or when you are listening, it's the dominant hemisphere which is working. Non-dominant is relatively relaxing. Yes, so alpha is a rhythm of relaxation. Yes. So you do a EEG very easy. And in the EEG, you find very good alpha on one side. That is the non-dominant side. Low amplitude, low frequency alpha is the dominant side. So that is the next level. Then in the olden days, people used to do intracarotid amytal injection. Instead, nowadays we do fMRI. If it is a VIP person, you are going to operate a tumor on the dominant side, he should not become aphasic. So he can be offered fMRI or depth electrode. People can, in a live patient, electrodes are implanted, they are stimulated and look at what happens to speech. So these are the methods. So one is handedness goes with tiredness. Then clinging the hands together, dominant thumb goes down. Then you can do the Edinburgh's bedside inventory and Edinburgh's research inventory. You can do the EEG. Then you can do intracarotid amytal, which is no more done. Patients are asked to hold their hands like this and count. When the carotid amytal, short-acting barbiturate, is injected into the carotid artery. If you are injecting into the right carotid artery, the left arm will drift. At that time, if that person's right hemisphere is dominant, he will stop counting. So drifting indicates you are in the right place, you are injecting into the right artery, and stopping of the counting tells you that is inside, in fact, the side of language. So that is handedness. It is very relevant. And supposing a left-handed person gets a vascular event, let us imagine. That is again some surgical and all those prognosticating relevance I told. Otherwise, in a patient with a cerebrovascular accident, supposing a right-handed person gets right hemiplegia and aphasia, and a left-handed person gets right hemiplegia and aphasia, it is said that 50%, only about 9% of the population is left-handed, and 50% of them have bihemispheric language. So it is not the left-handers are having right hemispheric, no. They are bihemispheric. Bihemispheric. So their prognostication for language is better. So that way also it is important. They might recover better from the language if they have left-handedness because they have bihemispheric representation for language. So that is one important thing in a case like this also, not necessarily surgical cases. So that is handedness. That's the first thing which is outstanding from the history. Next, you told that he is unable to hold the object with the right hand. No?
Yes, ma'am.
So holding object means what are the structures? We will go in the typical fashion, the functional impairment and its localization. Does it have an anatomical correlate? And is the anatomical correlate in a vascular territory, in a non-vascular territory? And does it correlate with the pathology? Like that we will go. No? So you told the first thing he noticed is unable to hold his coffee cup. No?
Yes, ma'am.
So what are the structures that are involved in holding the coffee cup?
Mainly the distal muscles and the mainly the fingers, predominantly the distal muscles, the wrist and the fingers, the distal muscles are involved in grasping the objects, ma'am.
Yes, for grasping, we tell two things. One is a precision grip, another is a power grip. Supposing your patient has told, he has started in the morning and started writing Nama Jabam or something like that, and he says that my pen dropped. That's a precision grip. But holding a cup of coffee is a relatively power grip. So you will tell my patient noticed problem with the power grip.
Power grip.
So that is the description of that function. Okay. Because holding a cup of coffee is a power grip.
Power grip.
Whereas holding a pen is a precision grip. And the precision grip involves fine muscles. If it is in the lower motor neuron, it involves fine muscles. What are all those muscles? Lumbricals and interosseous. For precision grip. Whereas here it is a power grip. It is a long flexors. So he could not hold the cup of coffee means it is a long flexors. And he told his sensations were normal. Even when the sensation is not there, they can drop it because they don't get the sensation. They will have to see the cup of coffee, feel it and hold it. But it was not like that. You told that the sensation was perfectly all right to go.
Yes, ma'am.
So my patient had a power grip loss and it is motor.
Yes,
that is the first information we get. From the first functional impairment our patient has told, we will tell he lost the power grip and it is motor.
Yes, ma'am.
And what are the structures involved? The structures involved from the lower motor to upper motor we can trace it.
Yes,
in the lower motor it is flexors of the forearm. Forearm flexors.
Yes,
so probably he had a problem with the forearm flexors. It can be at the level of the muscle, or it can be at the level of the nerve supply to the muscle, or it can be at the level of the roots that form the, or the trunk that forms, or it can be in the spinal cord, or it can be in the subcortex, in the motor cortex. That depends on whether it is upper motor neuron or lower motor neuron. So next question, we think it is motor now. We are sure it is motor.
Yes,
in the motor, is it upper motor neuron or lower motor neuron? That is the next question.
Yes, ma'am.
So, yes, ma'am.
Because it is acute onset, ma'am.
Yes.
So I would think of it being, it could be both upper motor and lower motor. Because if we take upper motor, there may be a spinal shock involved. So they may not have typical features like spasticity and stiffness of the limbs. All that
and
may not develop in the,
and the associated features you have told.
Yes,
you see,
and associated in the territory, associated like one side of lower limb weakness also is there.
And unable to speak. So you can say this person is probably having an upper motor neuron problem because of so many associations. Yes, but the same patient could have had a lower motor neuron also. Yes, because he had a fall. You see, he had a fall. So did he injure his plexus? Or did he injure some of the roots in the cervical cord? Or did he have a cord hematoma, traumatic dynamic spine injuries? They can produce a cord hematoma. No? Central cord syndromes, they present with upper limb only. Central cord syndrome, whiplash injury, they get upper limb. So, but you have to say, as you rightly said, your spinal cord does not involve the speech. It does not involve the lower limb. Other features like spasticity are yet to develop. It is in the acute phase. So, but I am telling you how to go through the steps. Yes. So upper motor or lower motor, you are right that it looks like an upper motor for the following reasons. But lower motor is very much to be considered. He had a trauma. It could be root, it could be plexus avulsion, or it could be a cord hematoma, it could be central cord syndrome. Central cord syndromes are sulcocommissural arteries produce a central cord infarction, where it is the upper limb which gets more involved because of the arrangement of the motor fibers. So you will say, so next question, is it upper motor, lower motor? You have clearly answered. So it looks like an upper motor neuron problem because of the associations that were there. Yes, then upper motor where? Okay. So where in the upper motor?
Yes, ma'am. So because there is associated speech that is completely lost.
Yes.
With the associated lower limb weakness, so I would like to place it at the level of the cortex, ma'am.
Yes. So it may be cortex or subcortex.
Subcortical. Yes. So cortex or subcortical. Yes.
So when do you say that I am sure this is cortex? So because of the association, it is less likely to be anywhere else. It has to be cortex or subcortex. And if you say, when will you say I am cortex? When will you say I am subcortex?
Usually if it is subcortical, there will be some associated sensory involvement also might be there.
There can be, yes.
Along with that, you will have a dense hemiplegia. And usually subcortical, the speech is usually relatively spared compared to a cortical involvement. Usually if it is there, maybe some conduction aphasia may be their maximum, but they may not have typical complete absence of speech. Speech involvement makes it more of...
So cortical functions. One thing you should tell, seizure at the onset.
Seizure.
The commonest feature of a cortical involvement is whenever the neurons, their cortex contains neurons. Yes. Whenever the neurons are irritated, they convulse. So if the patient says that I fell down from the cot, I threw a seizure probably, and when I woke up, I am having a weakness. So that means presence of a seizure is a definite cortical finding. Second, so subcortex does not produce seizure. Second, you can tell that monoparesis, because in the cortex, the homunculus is so much wide. You see, you have got a leg in the interhemispheric fissure, on the trunk in the superolateral surface, and head upper limb or little lower down in the superolateral surface. So if you have a monoparesis, that is more in favor of a cortex. But when there is, but this person had a hemiparesis. So points in favor, you as you said, involvement of language. Language, whether it is a language or speech, we do not know. We have to come and analyze that. So if the language is involved, if there are seizures, if there is monoparesis, that is favoring a cortex. But if there are cortical sensation, sensory loss, cortical sensory loss. But if it is a dense weakness and no language involvement and no cortical sensory loss, that will not suspect a subcortical. In this patient, there are points for both. Some points are suggesting he is unable to speak at all. So it can point to a cortex. But he had a weakness of one half of the body. So he never had seizures. So both possibilities we are keeping. It may be in the cortex or it may be in the subcortex. Both are possible. So we'll keep it like that. Then we will analyze the language and then decide. So next symptom you told is patient is, so we have got a weakness of the power grip, and that power grip weakness appears to be purely motor,
UMN type,
and it is UMN in type, and it is probably in the cortex or subcortex. So that is the analysis of our first symptom of holding the cup of coffee. But you told that he could lift his hand, no?
Overarm he was able to move. Shoulders he was able to move little again. Fully he was not able to move, but he was some movement was there at the level of the arm.
He did not have any root pains. He did not have any tract pain, no?
He did not complain of any sensory involvement, no sensory symptom involvement.
Neither positive nor negative. Neither positive nor negative. So that again makes it less likely that it is in the spinal cord. Because when only arm is involved in the history, everything is possible. So it is again a point favoring that it has to be upper. It has to be higher, not in the spinal cord. So that is about the upper limb. Next symptom you told is the lower limb or speech? Lower limb, no?
Lower limb.
Lower limb. What was the, you told that he had walking problem.
Yes, ma'am. He was not able to walk following the fall. He initially noticed the upper limb weakness, but on trying to get up, he found that he was not unable to completely get up from the sitting. He required support to move and walk around.
When he had to get up from the bed, what was his problem? Was he unable to bear weight on the leg? That was the problem, or was his tongue wobbling?
He was not wobbling. There was no. He did not have loss of position. When he got up from bed, he as soon as he tried to step, he fell down, ma'am. That was the history he has given.
So it is probably the bearing weight problem. It is not a truncaral. Yes. So when he tried to bear weight, he fell down.
Fell down, yes.
What does that indicate?
This indicates the weakness on the limbs. Motor weakness it indicates.
So it indicates motor weakness. He probably buckled.
Buckled, yes.
Did he trip or anything? He buckled.
No, buckled, ma'am. He didn't trip.
He buckled. Yes. That gives us what information? His power in the legs is less than 3.
Yes, ma'am. Less than 3.
Yes. If your power in the leg is more than 3, you do not buckle. You manage and you become clumsy. You get some support and try to manage. Yes, if the power is less than 3, you buckle and fall. So such a buckling thing. Next you said he has some problem in holding the chapels.
Yes.
Buckling, how will you analyze now? Somebody is buckling. So that is the next symptom your patient is. He buckled and fell down.
Yes, ma'am.
Yes. What all the additional information you will elicit in a patient who buckles?
if he had any pain associated.
Forget about this context, general. Yes.
Yes, ma'am. If he had any giveaway sensation in the limb when he was when he tried to step, ma'am. Any pain associated?
Yes. In this context, what is the importance of painful buckling? He had a fall previously, no? Did he injure his cruciate ligaments?
Yes, ma'am. Knee,
You see
local cause.
yes, the semilunar cartilages and the cruciate ligaments can break through injury to the cruciate ligaments, which link the femur and the tibia. They approximate the tibia and the femur. He fell down. He doesn't know what exactly happened because he was sleeping and he fell down. So did he injure his cruciate ligaments or the semilunar cartilages? So he had a painful buckling. So if there is a painful buckling, that will be very much
local cause.
Yes. You additional local may be there. He may have a neurology, but you will have to address it differently when you are giving therapeutic.
Thank you, ma'am.
So we were thinking whether we should consider injury also if there was a painful buckling.
Yes, ma'am.
So that's the first thing you told, whether it is a painful buckling or a painless buckling.
Yes, ma'am.
If it is a painless buckling, it is pointing a neuroparalytic buckling.
Yes, ma'am.
In this case. So as he said, the upper limb is involved, speech is involved, so it has to be in the upper motor neuron.
Yes, ma'am.
But if it is during the period of recovery, we ask whether it is a stiff buckling or a flail buckling. Okay. If it's a stiff buckling, it is pyramidal. Because in pyramidal tract, why do they buckle? Would you like to tell me? Why do they buckle?
Because of stiffness of the limb, ma'am, they can't hold it. Because of extreme stiffness, they can't.
If there is extreme stiffness and the power is less, actually they will not buckle. Because in such situation, you should not reduce the power. It helps them to stand.
Okay.
But what happens is there is something called kinetic melody.
Okay.
When you are standing, the knee extensor is the agonist. Yes. And knee flexor is the antagonist. Adductors and abductors are the synergist.
Yes, ma'am.
So for every motor activity, there is an agonist, there is an antagonist, there is a synergist and fixators.
Yes. Yes, ma'am.
Hearing, huh?
Yes, ma'am. Yes,
very sad. Very sad. So much
no, ma'am, not at all. It's such a privilege learning from you.
You understood my upper motor neuron, why do you buckle? Buckle because loss of kinetic melody. Yes, so there will be co-contraction and co-relaxation. Whereas in lower motor, it will be cardiac weakness or frontal neuropathy or L-tail radiculopathy. So in this patient, we know it is upper motor neuron. Yes, so we think probably this due to loss of kinetic melody and the power grade is less than less than grade 3.
Less than grade 3. Yes.
So that's a buckling. Next, you told he is unable to put his chappal and grip it.
Yes, ma'am.
Could he put his feet into the chappal? He could.
He could put his feet into the chappal. He could.
So he had precision power loss in the lower limb. No.
Yes, ma'am. Precision loss in the lower.
Gripping the chappal. Yes. So he had two things in the lower limb. In the lower limb also, it is purely motor. It is loss of precision grip in the lower limb and loss of kinetic melody.
Okay.
So in the upper limb, it is a pure motor weakness of power grip. In the lower limb, it is precision grip plus kinetic melody. That is the analysis of the two problems in the upper limb and the lower limb. Then we will come to the speech.
Yes, ma'am.
Would you like to use the word speech or language? Would you like to tell why you want to call it as a language or why you call it a speech? What are all the points favoring language? Would you like to tell me why you said it is language?
Ma'am, speech involves comprehension for framing proper sentences with the background knowledge that we have of that particular language, ma'am. So that involves the.
So language is. Tell me. Tell.
Yes, ma'am.
You tell me. Proceed. Proceed.
Yes, ma'am.
Language. Language is. I didn't stop the video. No, okay, that's not. Language is ability of the individual to convert thoughts into comprehensible modes of communication. You understand, ma'am?
Yes, ma'am.
Definition of language is ability to convert thoughts into comprehensible modes of communication. That means reading, writing, listening, speaking, everything.
Yes, ma'am.
What this means? Ability to convert language into audible sounds.
Okay.
So language is already there.
Yes,
Only the verbal communication is lost.
Yes,
So in your patient, apparently from whatever history you said, that he could comprehend, he could read, he could write, only thing he could not speak.
speak. Yes, ma'am.
So it's very difficult to tell it is language, except that your patient had right hemiplegia.
Yes, ma'am.
Data is inadequate to call it as language.
Language. Yes, ma'am.
Huh?
Yes, ma'am. Yes, ma'am. You're able to hear me.
So only speaking is affected, no? So
Yes,
it can be, so what all the things you would like to consider now? He is able to read, he is able to write, he is able to comprehend.
Yes, ma'am.
So very difficult to call it as a speech. It can be an acute anarthria.
Okay.
It can be an acute anarthria, or it can be a mutism.
Okay.
Mute state. Mute state people can communicate by writing. They can comprehend, but they will not be able to speak. So these are the two possibilities you will tell. You will not tell it is a language. It may be an acute anarthria, or it may be a mute state.
Okay.
So chronic anarthria, all of us know. Conditions like motor neuron disease.
Yes, ma'am.
Where patient's tongue becomes completely atrophic
Atrophy.
and they are not able to move it at all. Whereas acute anarthria, is there any level, any condition, you know, acute anarthria?
No, I don't.
There are, that is called capsular genu syndrome. Genu of the internal capsule, where the corticobulbar fibers are coming.
Yes, ma'am.
So the genu of the internal capsule. Anarthria, clumsy hand syndrome. You heard?
Yes, ma'am.
No,
Yes, ma'am.
peer motor hemiplegia,
Yes,
peer sensory. So it can be a genu. We thought whether the lesion is in the cortex or subcortex, and the only kind of cortex was the language. Now we think that language is not there. You see? So it may be subcortex, it may be a capsular genu syndrome. That is one possibility. Second possibility, it may be a mutism. Mutism in language happens in subcortical areas. Hearing?
Yes, ma'am. Yes, ma'am.
So mutism in subcortex happens when there is a subcortical language areas are involved.
Okay.
So subcortical language areas are areas which are covered in a quadrangle called Mary's quadrilateral space.
Okay, ma'am.
Mary's quadrilateral space is the area which connects the anterior lip of the corpus callosum with the upper lip of the insula and the lower lip of the insula to the posterior lip of the corpus callosum. If you do a coronal section, you will see external capsule, claustrum, putamen, globus pallidus, internal capsule, caudate and thalamus.
Yes, ma'am.
So any of these structures can present as an acute mutism. So these structures are called Mary's quadrilateral space.
Okay.
What do? They prepare the motor schema.
Okay.
Supposing I want to call you Balaji, I have to decide which lip I should be, which muscle should be recruited, how I bring out the correct phonation. No?
Yes,
For
ma'am.
that, the schema has to be prepared. That schema is prepared by the subcortical language area that is called Mary's quadrilateral space. So if that space is gone, language is still there, but it doesn't know which muscle to put into action and bring it out. So it will look like an element. So patient will be mute. So he can comprehend, he can read, write, but wordless. So that is the second location. One, it may be capsular genu.
No, you're able to hear, ma'am.
You are able to hear?
Yes, ma'am.
So third situation where a condition like this happen is angular gyrus. Angular branches of the middle cerebral artery.
Okay.
3 locations: capsular genus syndrome, Mary's quadrilateral space producing mutism, and angular upper division of the middle cerebral artery. They can produce the classical Jesman syndrome, conduction aphasia, or anarthria. Angular branches of the middle cerebral artery. So these are the 3 things you will. So this doesn't fit exactly into a classical aphasia because only communication is lost. So you will call it as either as an acute anarthria or mutism. So that can be explained in this context by capsular genu or Mary's quadrilateral space or angular branches of the middle cerebral artery. So we are becoming more closer to anatomical localization. So this has to be either in any one of these areas that pathology is happening. So what was the next symptom? So this is not language. You understood, no? It's not speech also.
Yes, ma'am.
Speech will be, yes, still ask, ma'am.
Ma'am, so apraxia, how do we, can this be like any form of like, without any weakness in the muscles, but can this be apraxia, ma'am?
Apraxia can happen, opercular syndromes, no? Apraxia happens, but that by examination, you should be able to demonstrate voluntary reflex dissociation. That is, he is unable to speak, but when he wants to move the lips and the mouth for ice cream or eating or whistling or playing a musical instrument, so there should be demonstration that this is in fact apraxia by demonstrating voluntary reflex dissociation. Apraxias happen when there is a parietal lobe involvement. It can happen. That will be by examination. Apraxia is one possibility you can consider. Okay. But it is little more denser weakness and sensory is not at all there. You see, if infarct is in the parietal cortex, it should be sensory. It should be focal. None of those things are there. So we are moving in the plane of a motor syndrome. So it is likely this localization. Apraxia is very much possibility if it was sensory. It was sensory. So these are the 3 main symptoms your patient had, no?
Yes, ma'am.
So would you like to club them together?
Yes.
So now it probably looks like a subcortical lesion.
Yes, ma'am.
Less cortical and purely motor.
Yes, ma'am.
And it is the pattern is, what is the pattern? The upper limb is more involved or lower limb is more involved? What is more involved, ma'am?
Here it's like both are almost equal, ma'am.
Both are almost equal. If they are equal, it is again favoring a subcortex.
Subcortex.
You see, if it is a cortical middle cerebral involvement or something like that, the upper limb will be more involved than the lower limb. Yes. So if they are equally involved, it probably points to again subcortex. So most of the features are favoring. Probably he was mute. Probably he was mute. Unless you listen to him, you do not know whether it is an anarthria or a mutism.
Yes, ma'am.
Mute patient will not produce any word at all. Whereas anarthric patient will produce illegible words. Mute will not produce anything. Anarthric will be illegible words. So when checking that only, we will know whether it is an acute anarthria or a mute state. We don't know. So probably it is subcortex. So second, you told it is fairly acute in onset.
Yes, ma'am.
So it is likely to be a vascular event.
Vascular
event. Likely to be.
Yes,
and you then what kind of vascular event you would like to consider if it is vascular event?
Yes, ma'am. I would like to consider thrombotic event or embolic. Mainly ischemic I would like to consider, ma'am, because there is absence of any seizures or any urinary incontinence or severe headaches that are there that are favoring more of a hemorrhagic involvement. So I'd like to think of a ischemic involvement, predominantly thrombotic or embolic.
What do you favor most?
More of.
So now we have analyzed the functional disability, which I told you, you should analyze. Next, we are finding an anatomical correlate, putting all the functional disability together.
Yes,
now we are trying to find out the pathology. So that's the third step from the history. You understand how to follow now, no?
Yes,
so you told it is ischemic. I also feel so because it was not associated with headache. and it did not wake him up from the sleep. But when he woke up, he saw it.
Yes.
Whereas hemorrhages wake up the patient from the sleep with a headache. Here he woke up and he found that he is falling down.
Yes.
Then most important point, it continued to progress. On his way to travel also, it was progressing. So would you like to differentiate hemorrhage and ischemia for everyone? All the features favoring a hemorrhage?
Yes, ma'am. Features suggestive of hemorrhage. One is severe headache.
Yes. Never before headache. Thunderclap like headache.
Thunderclap
yes.
Headache.
Yes.
Then seizures may be there.
Yes.
There may be signs of neck stiffness or rigidity may be present if there is
subarachnoid extension.
Subarachnoid hemorrhage. And there is no progression, sudden onset, and there is no gradual progression or gradual loss of recovery is less common.
One thing, vomiting. Invariably, vomiting is an accompaniment. They can have seizures. And if it happens in the sleep, rarely it can happen. If it happens in the sleep, it will wake up the patient from sleep. And generally, it happens when the person is active. Not while sleeping. And generally, the patients are young people. So, young people happens when they are active, never before headache, severe vomiting, with or without seizures, and drowsiness as an invariable accompaniment. Progression can happen. If it is hypertensive hemorrhage, it can progress up to some hours. Or if it is a drug-induced hemorrhage, if the patient is on blood thinners, or patient has got a bleeding disorder, they can have repeated bleeding, one layer, till the bleeding condition is controlled. So that can happen. Whereas thrombus usually happens in the elderly people. And if it happens in the sleep, it doesn't wake up the patient from sleep. Yes. He wakes up and finds. Are you able to hear?
Yes, ma'am, able to hear.
In thrombus, what happens now, ma? Headache can be there one day earlier. Because thrombus starts slowly. And when the thrombus starts building up, then the nature will try to repair by opening up the external carotid and the external carotid, internal carotid, non-functional branches. So that will produce a dull, pulsatile quality headache, which precedes the neurology by 1 or 2 days. And then he goes into neurology. That's the type of headache you get in thrombus. Then usually when they are less active sleeping, and it continues to progress, and the duration of progression is not more than 72 hours. Maximum period of progression is 72 hours. If it progresses beyond 72 hours, you will think of a stroke mimic, like a subdural, a metastasis, something like that you will consider. But up to 72 hours, it can progress. And seizures do not happen. Sensations, sensorium is not altered. Seizures can come much later, once the gliosis sets in and scar convulsions come. Convulsions come in the scar. So, and mortality is less, morbidity is more, because it is an infarct. They are left with more morbidity. So this person had a wake-up attack and he never had any seizures. He did not have headache. His sensorium is very good, you have said. He is able to comprehend, write, read everything. And he progressed. So it is likely to be a thrombus, likely to be ischemic, and among them thrombus. Would you like to tell about embolism? What are the features of embolism?
Embolism usually younger onset. Age is usually younger onset. There will be a source for embolus.
Yes.
Maximum at the onset, and then there is steady recovery. And increases mainly precipitated by exertion. And usually happens when the patient is awake.
So awake, active, young person, source of emboli is there, means it is very good if there is a known heart disease. And the neurology is maximum at the onset. And they can have a seizure at the onset. They can, but unlike a bleed, where they can have repeated seizures, embolism, there can be a seizure at the onset. Would you like to tell why seizures can happen at the onset in embolism? They may have small specks of hemorrhage, because embolic strokes are more having small hemorrhages. Specks of hemorrhages are common in embolic strokes than thrombotic strokes. because the vessel wall is also ischemic. When an embolus comes and blocks a vessel wall, the wall of the vessel also is ischemic. No, beyond the level of the emboli. And it immediately resolves. So blood will gush in. And the ischemic vessel is inelastic. So it will produce specks of bleed. So mild hemorrhages are common in embolic strokes more than thrombotic strokes. Because of that, they can have a seizure at the onset. So we have gone into pathology also. So at the end of the history, this looks like a purely motor syndrome. And the syndrome seems to be in the anatomical correlate is there, probably in the subcortex. And the pathology looks like probably vascular and most likely thrombotic for the various features which we have thought about. So now we will go to examine.
Yes, ma'am.
Yes, ma'am.
On examination, patient was left-handed. Patient is lying supine on the bed and is comfortable. He is conscious, cooperative, he is obeying commands. He is oriented to time, place, and person. He is moderately built and nourished with a BMI of 23.2 kg per meter square. The blood pressure in the right arm is 148 by 76 millimeter of mercury in the supine posture. The pulse is 78 beats per minute, regular in rhythm, normal volume and character. The arterial wall is not thickened. The peripheral pulses are well felt with equal intensities bilaterally. There is no radioradial or radiofemoral delays. The respiratory rate is 20 cycles per minute, abdominothoracic, normal pattern and depth of respiration with no accessory muscle use. Head-to-toe examination, there is no evidence of pallor, icterus cyanosis, clubbing, lymphadenopathy or edema. There is no obvious facial asymmetry. There is no xanthoma or acanthosis nigricans, no markers of infective endocarditis, or there are no neurocutaneous markers. Coming to the nervous system examination, higher mental functions, the patient is conscious, he is alert and is cooperative. Memory, immediate, recent and remote were intact. This was tested by asking him to write instead of speaking. Speech, the spontaneous speech was absent. The repetition and naming were absent. However, comprehension and writing were preserved. He is able to do mathematical calculations and able to identify the right and left side of the body.
So what do you think it is? It is more looking like a mutism only.
Yes, ma'am.
Everything is preserved except the ability to express by words.
Yes.
So it looks like a mute state.
If it is aphasia, this will not be preserved, no, ma'am?
No, aphasia, all the four limbs are there, no, ma'am.
Yes.
Yeah, even if it is Broca's aphasia, yes, there will be telegraphic writing.
Okay, ma'am.
There will be telegraphic speaking. Okay. And when you read, comprehension will be preserved. But at least one more limb will be affected, reading and writing, speaking and writing. In his case, you have said naming, writing, everything is preserved. That never happens in aphasia. If it is sensory aphasia, comprehension will go, he will be fluent.
Yes, ma'am.
In this case, the repetition is not going to help us because when he doesn't speak any word at all, repetition is not expected. Okay.
Yes. Coming to the cranial nerve examination, should I go to the inference or should I read out everything, ma'am?
If anything positive is there, because I am worried about this next problem.
Cranial nerve involvement is normal. There is no cranial nerve involvement.
Did you look for a subtle facial palsy, ma'am? Because we are expecting a subtle facial palsy at least, no? Yes, we are thinking the pathology is in the subcortex.
Subcortex.
No? So subtle facial palsy, how do you should look for in this case, definitely. What are the points you will look for to know whether at least a subtle facial palsy is there, or is it just hemiparesis without cranial nerve involvement? You will look at the palpebral fissure, mild asymmetry in the palpebral fissure. Blink rate. Is there any mild asymmetry? Normal blink rate is 15 to 20 per minute. So is on one side it is little less than that.
Okay.
Or you can tell them to tightly close the eyelid. The eyelashes may be jutting little more on one side. Then you can check the power of the orbicularis oris, orbicularis oculi. Even though you don't find any asymmetry, the power may be asymmetrical when you try to open. When you open, so you should definitely look for features of subtle facial palsy like difference in the blink rate, mild asymmetry in the palpebral fissure, incomplete burying of eyelashes, mild asymmetry in the power of the buccinator, orbicularis oris. No? Okay. Those things are very important for us.
Okay. I didn't look for so many points.
In this case, we have to look for because hemiplegia without facial involvement, even in the subcortex, is very uncommon, and it happens in venous strokes because venous territories are different from arterial territories or spinal hemiplegias. But at least subtle facial will be there in a subcortical hemiplegia, so that you have to look for that. Okay, go on.
Coming to the motor examination, ma'am, in the mental functions, is it sufficient for so much, or should we include anything else, ma'am?
No, because this person is
unable to speak.
Unable to speak even a single word. Other mental functions which need communication by speech, you will not be able to do.
What
else? But you can unless you have got, in this case, unless this case is your MD exam case, yes, unless there is evidence that he has a behavioral problem or he behaves as if he is not remembering his family members, there is no need to go to other mental functions.
Okay.
If you find that there is something like an apraxia which you asked me, then you can look for apraxia of the limbs, other parietal lobe features, line bisection test, finger identification, all those things based on what is suspected. If you feel it is an apraxia, you will go for all the parietal lobe function tests. If there was a behavioral involvement, you will look for temporal lobe functions. Like that, because all the
you should test, ma'am. Like in each lobe, what are the main points you should look for? Like dominant versus non-dominant.
This is supposing quickly, if you want to know, dominant versus non-dominant is language versus no language. That is the main difference between dominant and non-dominant. Second dominant hemisphere function is praxis. Dominant hemisphere has got two important functions. One is language, second is praxis, which is unique to dominant hemisphere. Except dressing apraxia, all other apraxia is dominant hemisphere. Then both others are all common. Frontal lobe is initiative, mood, depressed feeling, not wanting to do anything, executive function. So patient with stroke is refusing to cooperate for physiotherapy, is refusing to cooperate for treatment at all, just doesn't speak even though he is able to speak. No? So executive function, features of severe depression, withdrawal, that is all frontal lobe. In a case like this, otherwise degenerative disease, when you present one, I will tell you the whole frontal lobe. That's a very huge topic by itself. In a case like this, you will look for executive function mainly. When you come to parietal lobe, you will look for cortical sensation, finger identification, because we thought that the angular branches of the middle cerebral artery can present with anarthria. So does he having Jessman syndrome features like finger agnosia, acalculia, right left disorientation, all those things are there or not? Then you can look for line bisection, neglect, and the cortical sensory loss, and hemianopias of lower quadrant. Parietal lobe produce lower quadrant hemianopia. So if that was there, then if you take temporal lobe, you can temporal lobe, the commonest manifestation aphasia on the dominant side, and on the non-dominant side, it will be behavioral abnormality, upper quadrant anopia, uncinate aura, he may get olfaction. Those are the things in the non-dominant temporal lobe. Then you go to occipital lobe, main thing is hemianopia, contralateral hemianopia. But each lobe has got a lot of functions, each one is by itself. Sometimes you can take a case of dementia or something. In that case, one lobe. If you have frontotemporal, I will elaborately discuss that. Here, grossly look, my patient is not unduly depressed. His executive function is all right. and he is not having any sensory features. So I did not do elaborate parietal lobe testing. His behavior is all right. So temporal lobe testing not done. Hemianopia can look when you examine.
Okay.
In hemiplegia, hemianopia has to be elicited that you can look. Subcortical hemianopia can be involved. So you look for that. Occipital lobe also is very elaborate. Those who are interested, you can join our online neurology sessions, which we do on every Sundays, 1 hour, 3 to 4. There we have covered so many sessions we have completed. I will give that contact ID to your Dr. Krishna.
Yes,
Kishan. I will give it to Dr. Kishan. Anybody interested can get it from him and join. There we elaborately discuss these things.
Yes, ma'am.
Okay, ma'am.
Yes, thank you. So cranial nerves were normal. Maybe subtle southern nerve palsy might have been there. I've not checked for it, ma'am.
Or mimic facial palsy. You see, in the upper motor neuron facial palsy, you can have purely motor, purely emotional, or combined emotional and motor. So you should look for it. Maybe just emotion that is lost. Subcortex, no, thalamus, all those basal ganglia structures. So you can tell a joke and see when he is smiling, is there any asymmetry? So that is also important. It is very unique for upper motor neuron. Okay.
Coming to motor examination, there was no obvious wasting of muscles or any atrophy that was noted. A tone in the right upper and lower limb was reduced compared to the left. There was hypotonia, probably because of the acute shock, acute.
How did you inform it is hypotonia? What are all the points?
I compared it to the left limb, ma'am.
There was no resistance. Is
no
it so?
resistance to my movement. No resistance.
What
no.
are the? So you should tell that. You should tell that patient did not offer any resistance when I did pronation, supination. That is the subtlest spasticity is manifested in the upper limbs in the pronators and in the lower limbs in the adductors. So even though patient is shocked, it is already 3 days when he came to the hospital. No. So the shock should be slowly recovering. So you should look at the pronators. Very quick alternating movements of the pronators you should do. And in the lower limb, you should do quick movements of the adductor. So you should tell, I look for subtle spasticity. By quick alternating pronator and adductor, they are not offering any resistance. Second, any other point? You can shake the limb. When you shake the limb, more number of movements. More than 3 oscillations. When you passively shake the movement at the wrist, you get more than 3 oscillations. So that is another point for hypotonia. Third point for hypotonia, you tell the patient to keep his hands on the elbow, support his hands on the elbow, and keep the wrist flexed. In normal tone, it will be right angle between the elbow and the wrist. Hypertonia, it will be obtuse angle. Hypotonia, it will be acute angle. It will come down. So these are the various things. You can say least resistance, no resistance in the pronators in the upper limb and adductors in the lower limb. So there is no spasticity at all. Then the acute angle is formed when the hand is kept in the elbow supported position, and passive shaking of the limbs, the oscillations are more than 3.
Yes, ma'am.
Yes. So I inferred that it is hypotonia. Okay. Next one.
Coming to the power, ma'am. Power in the power at the level of shoulder joint in the right upper limb was 3 plus. It was reduced in the elbow it was 2 plus at the level of elbow. At the wrist, in flexion extension it was 2 plus, whereas abduction adduction it was 3 plus. At the level of hip joint, uniformly it was 4 plus. At the level of knee joint, it was flexion extension was 3. At the level of ankle also it was 3 plus, ma'am. Toe flexion extension was 3 plus. he was able to move it against gravity, but with resistance, he was not able to do it. So uniformly, impression
So
is
both upper limbs or lower limbs are involved. And which is better involved, proximal or distal?
Distal is
better,
more,
worst affected.
worst affected.
Yes.
Distal is more involved here than proximal, ma'am.
Yes. What does it tell us?
Again, this indicates UMN
Yes.
weakness.
The finer movements are more affected than the coarser movements. That is favoring the UMN which you are already considering. Finer movements are, it is showing a movement pattern, it is not showing a muscle pattern. So you did not find any difference between the flexors and the extensors, but you find the difference between the proximal and the distal.
Yes, ma'am.
So it is a movement involvement that is more, not the muscle. It is not showing any muscle pattern. It is showing a movement pattern, and the finer movements are most affected than the coarser movements. Yes, next one. And upper limb is more involved than the lower limb.
Yes, ma'am.
Lower limb.
Yes, ma'am.
So what is pattern call it? This pattern you call it as what?
This is suggestive of the MCA involvement, wherein the upper limb is more involved than lower limb, ma'am.
Yes.
Wherein usually the flexors, the anti-gravity muscles usually are affected whenever there is a pyramidal lesion.
Yes.
In the upper limb, the flexors, the lower limb, the extensors.
That pattern is not very much evident.
Not visible here, ma'am. Only the difference in the power is visible.
What do you think could be the reason? You think that there is an upper motor neuron type of weakness, the distal is more, it is a movement paralysis, not muscle pattern, nothing is there, and but still you are not getting the classical pyramidal pattern. What do you think? It is patient still seems to be in the shock, no?
Acute shock, yes, ma'am.
Yes, still patient seems to be in the shock stage. So the pattern will not come. Why do you get that pattern now? Would you like to tell why you get that classical pyramidal pattern?
Because
it happens during recovery only.
Yes, ma'am.
Why do you get that? What is the explanation given for that pattern?
Not 100%.
The flexors of the upper limb and extensors of the lower limb. No.
They recover earlier than the anti-gravity muscle tone power improves compared to the.
Yes. Why? You see now, when the cortex is there, when there is an infarction, what happens? Whether the cortex is infarcted or subcortex is infarcted, either there is a direct necrosis of the cortex or disconnection of the cortex. In a cortical infarct, cortex becomes necrosed. In subcortical infarct, cortex becomes disconnected.
Okay.
So when the cortex is disconnected, what happens? You cannot make voluntary decisions. You see, supposing, so ultimately the purpose of the nature in repair is to make the species survive. So for survival, you need feeding, you need locomotion. If you are not able to make, it's a reflex posture. It is called hemiplegic dystonia of Denny Brown.
Okay.
It's a reflex posture. So if the upper limb is extended, how will the organism survive? You have to eat, no. The cortex is not able to tell you, this is how you have to flex your hand and bring it to the mouth. So cortex is unable to tell, either because it is disconnected or it is necrosed. So the body reflexly fixes in the flexion posture of the upper limb. And survival also involves running away, fight or flight. In the wilderness, you have to run away. So it's a reflex posture for feeding and locomotion. In the absence of cortical volitional control over feeding and locomotion is lost. It's a reflex posture. It is not very evident in this patient because he is still in the shock phase. Next.
Coming to reflexes, ma'am, superficial reflexes. In the right side, the abdominal reflex was absent. Plantars were equivocal. It was mute, ma'am. The right plantar. The left plantar was flexor. And deep tendon reflexes were 1+ throughout in the entire right upper and lower limb. Probably this is again because he's still in the acute phase that
Yes.
he has not developed the exaggerated responses, ma'am.
So now what are the two responses which you are going to use apart from the distal pattern, distal more than involved pattern which is favoring a upper motor neuron? Now what other clues you have to use to say it is still upper motor neuron? Abdominal reflex.
Abdominal reflex is absent, ma'am.
So how will you differentiate an LM and abdominal reflex from EM and abdominal reflex? You have to do in such a situation, hypotonia is there, reflexes are not very good, no? Except that associated involvement of the communication skills. You are on like a cat on the wall, you didn't even get a proper facial, no? Yes. So you have to do a deep abdominal reflex and superficial abdominal reflex, two are there. You see, if you have a lower motor neuron, yes, it's a radiculopathy. It will knock off both the upper superficial and the deep abdominal reflex. So, yes, see, you put your fingers on the abdomen and percuss on your fingers. Yes, that's a deep abdominal reflex. That will produce contraction. Whereas if it is due to upper motor neuron, superficial abdominal reflex will be lost, but deep will be preserved. That can be utilized in this case. Okay. Because so many odd features are there. Some odd features at all levels are there. So odd features have to be cleared. So you should look for the superficial and deep abdominal reflex in this case. Then when you come to the plantar, it is mute on one side and it is readily flexing on the opposite side. Yes. That itself is good enough to call it as upper motor, but still you can look for subtle plantar. Subtle plantar, up going or down going. How do you do that? Mute is neither flexing nor extending. Opposite side is flexing readily. That is good enough. But you should try to look for other features which favor extensors. What all things you will look for now?
We'll look for the contraction of the tensor fascia lata if it is present, or any flexion, dorsiflexion of the knee and flexion of the knee, flexion of the hip with dorsiflexion of at the level of ankle.
So if any of those things are there, that is helping us. If those things are not there, you will call a friend and you will tell him to hold the thigh of the patient. And there is normally hamstrings and tensor fascia lata, both are contracting. When you are eliciting a plantar response, both contract. But which is more? Is the tensor fascia lata contracting more, or is it the hamstring contracting more? If the tensor fascia lata, as you rightly said, is contracting more, that mute goes with an extensor response. So it is a more supportive of a pathologist. So if you are asked subtle, you should ask for a friend. You should ask, I need one more person. Two people are needed. The other person has to hold the thigh and compare between the tensor fascia lata and hamstring and say whether the mute is really extensor or not. Okay. So that also you will do. You will do the deep abdominal reflex in this case, and you will also do the tensor fascia lata versus hamstring comparison in the thigh contraction in this way, so that you are very sure, because the subtle features we pointed out were there throughout as odd features. Then what else, no? Sensations?
Sensations were normal, ma'am. Probably it is not very adequate because he is not able to communicate that well because of the mutism, ma'am. But overall, he said on comparison, he didn't. There was no obvious sensory involvement that was there, according to him.
Then what about the hemianopia? Does he have?
Ma'am, tried eliciting. It was normal, ma'am. The visual fields both during simultaneous extinction and during single eye closure, both he didn't have any obvious visual field changes.
So, at the end, you summarize the findings and tell the odd features and where you would like to precisely put the pathology now after examination.
Yes, ma'am. So at the level of after the level of examination, so examination shows dominant loss of
Purely motor. Purely motor. No.
purely motor, yes, ma'am. Purely motor.
Purely motor.
No sensory involvement, no cranial nerve involvement, no no meningeal signs, no
Cranial
evidence.
nerve will keep correct. We have not looked for subtle. No, so that will put plus minus. Yes. Next one.
There is no carotid thrill or bruit also that was present, ma'am.
So it's a purely motor syndrome with anarthria.
Anarthria.
Or mutism. Yes. Anarthria or mutism. So it comes under the category of a lacume. You are not expecting a major artery infarction with these findings. Yes. So it looks like a lacume. Under lacumes, you have got purely motor, purely sensory, ataxia, ataxic hemiparesis, dysarthria, clumsy hand syndrome. So you can put it as a pure motor, but dysarthria is there. So under the lacunes, the most appropriate will be pure motor with anarthria. That is the dysarthria, clumsy hand syndrome. You can have some degree of involvement of the lower limb. That is one possibility. Another possibility, in that situation, this differential involvement will not be very evident. If it is a dysarthria, clumsy hand syndrome, the upper limb more involved than the lower limb. That pattern is usually not that evident. Both are slightly weak, they are clumsy, and the power is around grade 4, and dysarthria is manifest. Like that only you get the dysarthria, clumsy hand syndrome. But here it is significantly weak in the upper limb with grade 2 power in the distal upper limb and grade 4 in the lower limb. So this pattern will not be forthcoming very typically in the dysarthria, clumsy hand syndrome type of lacume. So the alternate possibility will be middle cerebral branch occlusion. Because you are having a middle cerebral pattern. Middle cerebral pattern is there. And middle cerebral divides into upper division and the lower division. Lower division will produce a sensory aphasia. Whereas the upper division can produce motor aphasia, or if it is only the angular branch, which it appears to be because it is purely motor, it is not a large infarct. So first possibility, is it a lacume? Points against or points unusual or the MCA pattern, classical MCA pattern, which is not usual in the lacume. So it is likely that it is a branch of the middle cerebral artery, most probably the angular branch, which can be motor and it can be with anarthria. So at the end of your history and examination, it appears to have only two differential diagnoses, of which the now first will be the MCA branch occlusion for these reasons which you are going to tell. So now we will have to investigate. Huh?
Yes.
So you investigate. So it looks like a thrombotic infarct affecting the dominant middle cerebral branch occlusion, middle cerebral branch in this left-handed person. Yes. And left-handed person having some features suggestive of an upper motor neuron type of speech, whether it is anarthria or dysphasia, we are thinking it is more an anarthria. So either side can be put, but the lesion is definitely on the left side. No. But so what do you want to tell about his language? Language is obviously not affected. Probably his language is on the opposite side. So that is the second. His language may be correlating with his hand dominance. It may not be those cases where the language is bihemispheric. It probably his language is on the right side. That is the possibility. Or sometimes in your exams, people can ask, can there be an ipsilateral hemiplegia? Right-sided lesion and right hemiplegia. Can it happen? It rarely happens in supplementary motor area. It will be very brief. Because supplementary motor area has bilateral control. Okay. That is lesion on the right side, ipsilateral area 6, supplementary motor area is involved. So So that is also a possibility. Very less likely, I feel it is language dominance of this patient is on the right side.
Right side. Okay.
Probably.
Ipsilateral more. It is
Weakness.
area 6, ma'am.
Yes. Ipsilateral motor is area 6. Ipsilateral sensory is area 7. Okay. So these two lesions can produce ipsilateral or bilateral. All can happen. Area 6 can produce ipsilateral weakness, contralateral weakness, or bilateral weakness. Similarly, area 7 can produce ipsilateral sensory loss, contralateral sensory loss, or bilateral sensory loss. So these are unusual things which you can do it as a mental exercise and not feel surprised when you find lesions in unusual locations. So these things are there in the neuraxis. Then you go on. You tell me what examination you did, investigations.
Don't
you told me what do you think is the comorbidity probably in this case?
Comorbidity
He was a chronic diabetic.
Chronic diabetic, smoker, and hypertensive. All three increase the rate of atherosclerosis, ma'am.
Yes.
So probably it is again thrombotic. It favors more of a thrombosis.
Yes. With reference to smoking, people always ask one interesting question about the study of Hill and All. Study of Hill and All. That is a study on smoking doctors.
Okay.
So Hill and All interviewed smoking doctors. They didn't tell them to stop. Then after 5 years, they went and met them.
Yes, ma'am.
They found that at the end of 5 years, 1/3 of them were severely disabled, another 1/3 was sick. And at the end of 10 years, they found that 1/3 was dead. So that is extrapolated, it is equal to any death in the World War. So this is a very famous study of smoking, did not involve any major research. It's a study of Hill and All on smoking doctors. And I think you should know about the smoke years and all those things from your exam point of view. I'm sure you know all those things. And the diabetes control. So it apparently looks like well controlled. You told it was 87 at that point of time.
Yes, ma'am. At that point of time, it was 87.
So it was good or bad for him? 87 at that time. It is good.
Good for him.
Because
hypoglycemia again can worsen. Or
yes. Any stroke in the fed state is bad. In the starving state is good. Would you like to tell why, ma? Why fed stroke is bad? Because two pathogenesis is taking place when there is a stroke. When there is an occlusion, there is loss of glucose, loss of oxygen. That is a primary pathology. But this loss of glucose and loss of oxygen will produce a metabolic derangement. That's a penumbra, where free radicals are going to be released. If the glucose level is very high, lot of free radicals will be produced. So fed state is bad with respect to the second mechanism involved in expansion of the stroke. So glucose is supplied more free radicals. That is in the state stroke. So two levels pathology. Loss of glucose is there, but that can always be compensated at 87 by oscillatory mechanisms. But lot of glucose is supplied means the second thing, the penumbra will expand. So, so what else you found in examination? So,
ma'am, apart from neurological examination, the other system examination were all normal, ma'am. Didn't find any in the cardiac examination, didn't find any murmurs or a wide split of the second heart sound or any added sounds. Respiratory system also is normal and normal per abdominal examination, ma'am.
So that this okay. Tell me.
Systemic examination was within normal limits. Couldn't find any obvious cardiac abnormalities in the systemic examination, ma'am. So, like you said, two differentials. One is at the level of pure lacunar stroke, purely motor lacunar stroke with anarthria.
Or angular branch of the upper division
of the middle cerebral artery branch.
That is the first possibility, more likely.
Yes,
and in this patient, your NIH score and the Barthel index is only for prognostication.
yes,
Because he has come 3 days later, you are not going to consider any thrombolysis or anything.
Yes, ma'am.
So how are you going to treat this patient, ma'am, before it goes off next? Did you find any use of this session, ma'am? I am very sorry, so much breakthrough.
It has been so simplified, like each symptom deciphering at this amount in history only, like almost all the diagnosis is done. Like, thank you so much, ma'am. I don't think it would have been more simplified, and we don't think we'll get it in textbooks also, even if we read.
But being with children like you is my unexplainably pleasurable experience. But next time I'll become wise, so that I'll try how to prevent this break. So what did you find, ma'am, in the imaging?
Full report I couldn't get, ma'am, but they had given it as a lacunar stroke. I don't have the imaging findings, ma'am.
Okay.
They had given it as
so we are correct only. So we are correct only. No.
Yes, ma'am. It was given as lacunar stroke.
You have written somewhere that he is an elderly person. No, he is not elderly. Only
middle age.
Yes, 50 years. Yes. And how do you define lacune? At the end, you just close with defining lacune. 4 classical, purely motor, purely sensory, dysarthria, clumsy hand, and ataxia, hemiparesis. And even then these are the named lacunes. Then you have got multiple lacune syndrome, which will present like a dementia. And you have got unusual lacunes, PR wrist drop like presentation, so many things are there. So still I feel it is an angular branch of the middle cerebral artery that may be the culprit considering the pattern.
Okay.
So you will be asked to define what is a lacune. So lacunes are ischemic infarctions in the distribution of deep penetrating vessels. Right. Okay. So it is not cortical, it is closer to the subcortex. So ischemic infarctions in the distribution of deep penetrating vessels. So how are you going to treat this patient?
Since he is outside the window period,
yes.
So first is the imaging to find out. First is the basic investigations, ma'am. Routine investigations, the CBC, the renal function test, HbA1c to look for glycemic control, and ECG if at all we are able to get any change or any arrhythmia if we are able to pick it up. Imaging would be a cornerstone for making the diagnosis. So if usually CT, brain plain CT or an MRI, if a patient is very much affordable, then we'll go for an MRI. Because it is almost 3 days and history
primary intervention is out of question.
Out of question, ma'am.
Yes. So now we are going to give him comorbidity control. No?
Comorbidity control and rehabilitation. Because
antiplatelet or anticoagulants. You put antiplatelet, Corey anticoagulant. Why you put Corey anticoagulant?
More of anticoagulant is what is being said, ma'am. Antiplatelets, because it is out of window period, dual antiplatelets for 21 days, followed by that single antiplatelet aspirant to continue.
Yes.
If there is any evidence of atherosclerosis that is there, if at all we find some atheromatous plaque in the carotid Doppler or something, then we may add on statins, or we can add statins based on the ASCVD risk score.
Yes.
Assessment. And adequate control of glycemic and BP control. And because it is ischemic infarct and it is outside out of the window period, so we can reduce the BP slowly compared to acute reduction in the BP.
How much BP can be allowed at the acute phase, ma'am?
Not
up to a diastolic of 120. Up to a diastolic of 120, you need not bring down.
Bring down. Yes.
It will maintain the perfusion. Anticoagulants, definite indication is dissection. He had a fall. So if you had a dissection, anticoagulants are indicated. Otherwise, venous strokes, procoagulants test, that is protein C, protein S deficiency, or cardioembolic. So these are the definite indication. Dissection, venous strokes, procoagulant state due to deficiency of all these things, or cardioembolic or arch of aorta. Otherwise, rarely anticoagulants are involved when there is a progressive thrombus. In spite of all methods you have tried, you can give. Definite indication is the first 4 only. Yes. So anticoagulants you need not put as a chorea, I think, yes, in this case.
I'll remove this.
Yes. Then of course you have put other things. And his prognosis is good for the current episode. Yes. For the current episode. He should protect himself from the subsequent episodes. That is the main. You have to prevent further episodes happening by addressing all the comorbid conditions. Thank you very much. This is a nice case. Some unique features were there. I am also happy.
It's great privilege learning from you, ma'am.
Any number of times I am prepared, but I think I should shift to the phone, I think. Is that better from the phone? What do you say? Phone will be better, huh? These breaks up will not be there.
Both are almost same, ma'am. Maybe
Same,
some issues in the internet, the connectivity, little bandwidth, if it changes little, it happens, ma'am. Otherwise...
I am so grateful to Kishan and all the young boys. I am so grateful to you, ma'am. Thank you so much. Call me whenever you are free. I am at your service.
There,
ask questions.
This has been there in Zoom as well as it is telecasted in YouTube simultaneous live stream, ma'am. Everyone have conveyed sincere gratitude and thanks for such a session.
Thank you very much. Ask the questions.
Madam, Madam Kishan.
Yes, ma'am.
Patient was speechless for some reason. Okay, that we diagnose. Yes. You diagnose now, but now can you tell me? We are also speechless, ma'am. All the audience are also, you made us speechless. That's all I can say, ma'am. Like we had heard about you, we knew something about you, but today we really realized, ma'am, you are a legend, and why so many, all the students love you, why they adore you so much, why they respect you so much. Really, you made a point there, madam. Yeah. I would request you to again, ma'am, on some other topic whenever you are free.
Yes, ma'am. Yes, ma'am. You tell me when you are free. As I told you, between 9 and 4 I am engaged. Otherwise, I am free only. You just inform me. We will meet.
Yes, ma'am.
Yes, ma'am.
Thank you so much. God bless all of you. Yes, ma'am. Yes, ma'am.
Yes, madam. Yes.
God bless all of you. Thank you.
A wonderful presentation. Yeah.
Thank you, Balaji. Nice presentation. Very.
Thank you for being with us. This was when ma'am readily accepted immediately to take a session for us. And thank you for Kishan sir for this wonderful platform, and thank you for being with us, ma'am. And
thank you. I am always with you.
To always guide us constantly, and we hope to keep learning from you always, ma'am.
Whatever I know, I will share with you.
And this is ma'am's book, Human Cognition as We Understand Today. And this is the blessings ma'am has given for all of us. Thank you so much for the wishes and blessings, ma'am. We hope to constantly learn from you always. You are a source of constant inspiration for all of us, ma'am.
Thank you so much. Thank you. Thank you, all of you. Thank you.
Oh, thank you once again, Vijay, for your volunteering this case presentation. We shall have this about detail about management in another session.
Yes, sir.
Thank you all the members for joining us and bearing with the technical glitches. Thank you, everyone. Shravan, so shall we conclude this session?